My name is Dr. Derek Lee, and I'd like to introduce the Chief of Staff and a pediatric orthopedic surgeon at Shriners for Children Medical Center in Pasadena. Welcome, Bob Cho, Dr. Bob Cho.
Hey, nice to meet you. Nice to see everyone virtually. So thank you for having me on here, Dr. Lee.
My pleasure. Now, this is my first time meeting you, but you've met my son before, and
Sure.
we'll touch on that a little bit later in the operating room in Shriners, Philadelphia. Okay, but I'd like to kind of go back a little bit to a little bit of your history and how you came to this point in your career and taking the next step into vertebral body tethering. Now you completed your undergrad degree at Cornell in chemistry, correct?
That's correct.
Was that your pathway originally to becoming a surgeon, or did you have that as part of your action plan to begin with?
Yeah, so I thought I did want to go into med school coming out of high school. I thought I wanted to be a surgeon of some type. And I had interest in sports medicine, actually, because I'm from the Philadelphia region. And my goal in life was to be the team doctor of the Philadelphia Eagles. So I went to Cornell, and chemistry was my major. I studied there, graduated with honors. My honors thesis was in theoretical chemistry, really, organometallic ligands. But that's not what the path that I wanted to take. It was just a step for me to get to med school, and Cornell was wonderful, but doing a chemistry major allowed me to essentially take most of the prerequisites for med school. I really wanted to come back to Philadelphia for my medical school. I wanted to be closer to home. And so I went to Drexel University for my medical school, and then subsequently my residency training. And the big thing for me is the reason I went there at the time. Drexel University was the team doc. They were the team docs of the Philadelphia Eagles. So my entire goal in life was to be the team doctor of the Philadelphia Eagle team surgeon. And then when I went to residency, in my second year of residency, I realized, because we were taking care of professional athletes, although I liked the surgical part, which was using a lot of arthroscopic equipment, that you use cameras and tools to get into very small spaces, into joints. I really didn't enjoy taking care of professional athletes, which was kind of a bummer for me, because I'd spent a lot of my life, training to get to that point. And then when I was actually taking care of professional athletes, I really didn't enjoy it. I enjoyed the technical parts of the surgery, and I enjoyed patient care, but professional athletes are a little bit different of a breed. And I just didn't feel like that was my path in life. And so I almost had a little bit of a crisis in confidence, at that point. So, but thankfully, and, I guess we'll get to it, but later, I ended up meeting some people, and my path just completely changed.
Who did you meet?
Yeah, so in my residency, this was just chance. And I didn't go into my residency to be a pediatric spine surgeon. Right after taking care of professional athletes, my next rotation was actually at the Shriners Hospitals for Children in Philadelphia. And the people I met there were really instrumental in helping guide me along my career. In particular, Dr. Randy Betts he took me under his wing. He heard my story. He took a liking to me, and he was the one who encouraged me to pursue a career in pediatric spine instead of sports medicine. And the other person that I met that was incredibly influential in my life, there was a new surgeon that had just started, brand new. His name was Dr. Amr Samdani. And so Dr. Samdani had just started at the Shrine, and I was one of his very first residents. If not, I might have been the first resident of his, I can't remember.
Okay.
And so, I learned a lot from both of them. And after spending some time with both of them, I realized that was the type of career that I wanted. And that in my third year of residency, I switched over completely to making pediatric spine my goal.
That's fascinating to see the interconnection. I always wondered about the tradition being handed down from Dr. Betts to Dr. Sandani than Dr. Cho. Fascinating,
Yeah,
actually. Okay.
I'm really honored to be just named with those two surgeons. They're wonderful surgeons. I've learned so much from them. I mean, Dr. Betts is really the godfather of what we do. And the previous device before Tether was a device called the Vertebral Body Staple. And with Dr. Betts, I had put in, hundreds of staples with him into many, many kids. And even though the staple itself has been superseded by, the Tether, the idea is the same kind of idea to provide a fusionless option that allows kids to maintain mobility and use their own growth to help correct curves, which I think, Dr. Betts was ahead of his time.
And he continues to be. I spoke to him just earlier this week, actually. And some of the things he's thought about 20 years ago were revolutionary at that point. I can't wait to see what he has in store.
For sure.
Fascinating, actually. I think that's a real genius, to be honest with you, certifiable. In terms of, so it's, I had no idea in terms of your experience with the stapling. At that point, when you were trained at Philadelphia Shriners, what happened from there on in terms of your career path?
Yeah, so it was, Dr. Betts in the beginning of rotation, he asked me what I wanted to do. And at first, when I first got on the rotation, I said I wanted to do pediatric sport, or I'm sorry, professional sports medicine, but I told him I hated it. I really, really disliked it. And I was kind of in a point where I didn't know what I wanted to do. He kind of took that to heart. He took me under his wing. We did lots of surgery, and he really taught me a ton about spinal surgery and how to take care of patients, how to, run a hospital. I learned so many lessons from him. And Dr. Samdani, if anyone who knows Dr. Samdani loves him. I mean, he's just really the nicest human, but he's, incredibly brilliant and incredibly technically gifted. And so, I realized that you could be a really, not loving, empathetic, caring surgeon, but you could also be a, technical superstar. You could, you could really, you didn't have to be kind of the stereotype of what the surgeon was on TV, this really cold person who yells at everybody. It wasn't like that at the Philadelphia Shrine. And so for me, it was eye-opening that, that these people are the world experts at what they do, but they operate in a manner that is pleasant. They really care about their kids that they take care of, and that was probably the biggest influence for me in my entire training. So Dr. Betts, at the end of the rotation, he asked me, well, Bob, what do you want to do? And I said, well, Dr. Betts, I really am interested in pediatric spine. And I said that, I asked him what he thought I should do or where I should train further to learn more techniques. And it was actually Dr. Betts who recommended that I go to San Diego to train under a man named Dr. Peter Newton. Dr. Betts has always been in my corner. So, when I went to interview at San Diego, Dr. Newton, he was made aware that I knew Dr. Betts, and I was highly recommended. And so it made the interview process relatively easy. I only went on one interview. It was San Diego or bust. And okay. They offered me a fellowship position, which was great because that's the only place I really wanted to go. So coming from Dr. Betts and Dr. Samdani, and then going to Dr. Newton, Dr. Newton is, exactly the same. He's a wonderful human. He's loving. He's empathetic. He's such a wonderful teacher. But he is technically, one of the most gifted surgeons I've ever seen, if not the most gifted. And so you learn a lot from surgeons like that on how to carry yourself in the operating room and not in the operating room. So, I try to emulate myself on those three people, Dr. Newton, Dr. Betts, and Dr. Samdani. They were really the biggest three surgical influences in my career.
Well, from what I hear, your technical skills are also quite superb. So, and you're learning from the best. So it sounds like you're going to carry on that tradition.
Well, I appreciate that. I mean, those are big shoes to fill, and I'm just one of their disciples. So I'm happy, and I talk to them all frequently as well. I just talked to Dr. Samdani and Dr. Betts last week. I talked to Dr. Newton a couple weeks ago. So, it's a pretty close-knit community. Being one of their former trainees, it's just an honor to be named, even in the same breath as them. They're amazing people.
Well, obviously they have, complete confidence in you. Is it normal, or that's the way it kind of works within surgeons within Shriners, or does that relationship extend into other different centers as well? Well, I guess with Dr. Betts, he's graduated to his own facility as well, or his own center, right? Okay. Right.
And so Dr. Betts has moved on to a center in Princeton with Dr. Antonacci and Dr. Cudahy. It is a small community. I think the Shriners group tends to be close because we're all in the same system. We all share the same mission, which is to provide, world-class care. In my case, paediatric spine care for kids. And we see kids from all walks of life, regardless of ability to pay. So I take care of a lot of international children with really severe spinal deformities. Those kids are not usually appropriate for tethers just because they usually have really, really bad spinal deformities that require just different types of operations. And so the Shriners spine surgeons tend to be a pretty close group, but because our spine community worldwide is relatively small. I mean, the Scoliosis Research Society, I think, only has it's not quite 1,000 members that are surgeons. I think it's something like 700 or 800 members. We all kind of know each other.
I assume it makes for very a rich research and just collegial integration of research, and even trading cases in terms of opinions, I guess, as well, right? Okay.
For sure. And that's, it's funny because that's exactly right. So, before we did our first tether, like I ran my x-rays, ran the x-rays of the patient by to Dr. Newton, Dr. Samdani, and it was actually Dr. Miyanji, who's my good friend up in British Columbia. Just to hear from, the masters and to be able to hear what they would do, helps me to make sure I make the right decisions. Because I think for most surgeons, when you get to a particular point, it's not the technical parts that I think are difficult. It's really just the decision making and, what you should do and a little bit of the nuance of how you do it. And that's where I think the mastery really is.
Okay. What's your relationship with Dr. Miyanji? I'm actually talking to him. I've spoken to him a couple of times, and I'll be interviewing him next week. Do you have anything for me to say to him, or would you like to say to him?
Dr. Miyanji and I are both, we know each other because we're both former fellows of Dr. Peter Newton. Okay. So I've known him for a long time through the San Diego Alumni Network, and many prominent spine surgeons have come from that San Diego tree. So like Dr. Stéphane Parent in Montreal, Dr. Ryan Goodwin, who's the chief at Cleveland Clinic. I mean, and then Dr. Miyanji, who's up in Vancouver. We're all former fellows of San Diego. Okay. And we all learned under Dr. Newton. So I've known him since I was a San Diego fellow. He's a couple years ahead of me, I think 4 or 5 years ahead of me. So he took me under his wing too. And, as he was rising up academically, I asked him to mentor me. And so he's always been a mentor to me. I talked to him, it's funny, I talked to him just a couple of days ago, just on an academic project we're going to be working on. And he really was the one who coached me probably the most for this last tether. We ran the cases through. We talked all the technical details. He helped me make sure that my room was set up in the appropriate position, and with all the cameras in the right spot, and everything went flawlessly.
Okay, excellent. In terms of vertebral body tethering, what motivated you to get involved in that and to become certified and take that on?
Well, that's a good question. So, I had always been interested in the idea of a non-fusion option in kids because I've always felt that although fusion should be an option for some kids, like I said, the severe deformities that kids who are done growing, tether's not, in my hands, for those kind of deformities, a great option.
Mhm.
But in kids who have growth remaining, I've always wondered why we don't utilize the growth that the kids have, to be able to correct a curve. And so Dr. Betts, like we talked about, he was ahead of his time. He knew that we um, we should use that growth, and we should use the body's own ability to heal to be able to correct itself. The device we used at the time, the staple, I think the idea was wonderful. I just don't think in some kids that had it, it was powerful enough to be able to correct the curve. So I think the difference between the staple and the tether is not the idea. The idea is exactly the same. It's that the tether is just a much stronger device and can correct much bigger curves reliably. And so for me, I wanted to get into tethering a bit earlier, and I talked to Dr. Samdani a lot about it. The biggest concern that I had was that it was when it was being done. I think Dr. Samdani was the one of the pioneers of it, and Dr. Betts was as well. Um, I really wanted to see kind of what the mid to long term results of this were going to be before I jumped into the waters. And I also wanted to make sure it was FDA approved, just to make sure that we weren't using a device off label. Not that that's wrong, and I think a lot of kids have had a good kind of go at it. It's just that if you're going to use a device off label, you should really study it closely, and it should only be done at a few centers to tell the FDA whether or not something is safe. And so when you have centers like Dr. Betts and Dr. Newton and Dr. Samdani doing it, I wanted to see their results first. Once it got FDA approved, once I was able to see some of the midterm results, I felt comfortable doing it in my own practice.
What's involved in actually learning a whole new technique like that
Well,
and,
that's a good
becoming
question.
certified as well?
That's a good question. So even before the tether came out, I think you have to, obviously, you're not going to have someone who's not a pediatric spine surgeon do these operations. So it's really only to pediatric spine surgeons. And even then, I think I had a little bit of a predilection for it just because of my training. I trained with 3 of the biggest names in this particular field. So I was very used to doing anterior surgery. We had done plenty of thoracoscopic surgery. So it's not that each of the steps was not a new step to me. It's just that the device was a little bit new and had some nuance. And so I really want to give kudos to the company that makes the tether, Zimmer Biomet. They have gone above and beyond to make sure every surgeon who gets this, who learns how to do this, is appropriately trained. So the FDA requires, and Zimmer requires, before you put this device in, you actually have to fly to their headquarters in Colorado, right outside of Denver. And you have to learn at their lab. You have to get all-day lecture with a lab on a cadaver or a model to show that you have some proficiency in doing this.
Mhm.
So, and it's a really select group of people. When I went there, my training session, I was in the second training session ever, I believe. There were only about 15 people there. So it's not a lot of surgeons that have been trained to do this. I was fortunate to be one of the early ones. And then, so you get trained, and then it's a matter of finding the right patient, obviously, that you feel comfortable, and that the patient feels comfortable. And, I had to tell my patient, hey, I'm very comfortable doing anterior surgery, but this particular device I've never used before. I've been trained. I went to the training course, and then the other thing that I got to do, which really was fortunate for me, I want to thank you, Dr. Lee. I actually got to watch your son's surgery. I flew in from Los Angeles to Philadelphia, which is my hometown, which was great. I got to watch your son's surgery, and that, I think, is the biggest key for any surgeon who wants to do this type of new procedure. Because regardless of what's written in the manuals, regardless of what you see on videos, of which I've watched, many, many videos and read all the manuals, when you see a master do it, you learn all the little tricks and the little nuances that are that the master does, and then also how placing particular portals, how to get a patient operated on safely with minimal blood loss and in minimal time, just for efficiency. And so that was really the culmination, to watch Dr. Samdani operate on your son. Obviously, your son had a wonderful result. From what I hear, he's doing incredibly well still. But and I encourage anyone who's watching this video, really, if any of the surgeons that you are getting an operation with, if the surgeon asks you, hey, is it okay if this other surgeon watches the surgery? I encourage you to say yes. And it's only because you saying yes is going to mean that other kids are going to be able to get helped from this. So because of your generosity and Dr. Samdani's generosity as well, I'm able to do this now for all the kids in LA.
Well, it's my pleasure. And to be honest, Dr. Samdani could ask me anything. I always said, absolutely.
Yeah, he's wonderful. He's so wonderful.
Yeah, he has that quiet confidence that you just say yes, you know what I mean? Because his judgment is going to be dead on every time.
For sure.
Now, there were also, I believe, he asked permission for if the Zimmer techs could also be present during that surgery as well. What are they looking for? What's their involvement in these procedures?
Yeah, so almost the way I think of it, and to use kind of like non-surgical terms, it's kind of like if you're putting on a play, or putting on like shooting a movie, right? I'm on the screen, so I'm like one of the actors, right? But there's a whole host of people that are behind the screen that actually are really important to make sure surgery goes well. So I consider the Zimmer reps to be essentially like the cameraman and all the other people that the producers, really, to make sure the implants are in the right spot, the instruments are all appropriate, the correct length, the correct location, that the scrub tech that's handing me the instrument is well trained. So they take care of all of that to make sure that all I have to concentrate is on the patient, And so we had 3 reps in my room during the last operation that I did. And it's because we had one person who was really familiar, and then we had 2 other people who were less familiar, who were learning how to do the procedure on their end. And so, we had Dan Baran, who has been in like hundreds of tethering procedures, which was comfort for me, and then we had other people learning from him how to take care of all the other things.
Okay, it's pretty fascinating in terms of the timeline and how even the instrumentation develops and changes, because I guess it's been about a year, just over a year, where Zimmer has come up with some new hardware in terms of screws, that type of thing, different sizing, different profiles. Have you had experience with what both pre and post the new Zimmer equipment looks like?
Yeah. So it's gone through a lot of different generations. So I've used the old DenaSys device, but not for a tethering purpose. I've used it in adult spine surgery. The original indication was for adjacent segment for adult spine surgery. So I was really familiar with the DenaSys device. The new device, the Tether, is a better device because the implants are smaller. Meaning like the prominence is smaller. So being around the viscera of the lung and the heart, you want to have devices that are as small as possible so they don't irritate those organs. The edges have been rounded off so that they create less irritation. The tether itself has been modified so that it's stronger, and then it has markings on it that show the kind of areas that are really the strongest area of the tether. I would say, and then the tether itself, they have multiple different sizes just because, I'm probably not going to put in the same, screw into someone who's a child versus, say like Shaquille O'Neal, right? Like they're just.
I hope so.
Exactly. So your son would get different implants than Shaquille. So we have to have different sizes. And so it's really, really well thought out. And, I'm really thankful that, people like Dr. Betts and Dr. Samdani, Dr. Miyanji, they were involved in helping to develop this. After hundreds of, cases using the DNASys, really modifying this and making this a beautiful device.
Okay. Well, this is the first time I've heard of modifications in terms of a new tether.
Mm-hmm.
Is it quite significant than the previous tethers, and how long have they been using the new tethers for?
So the old tether, they're made out of the same material, which is polyethylene terephthalate. So it's just a polymer. It's like a polymer rope. That's the best way I can think of it. So if you've ever gone like rock climbing, it's kind of like your rock climbing rope, mm-hmm. except with surgical tolerances and with smaller, obviously, so that it can go into a spine. The biggest difference is that is in the delivery mechanism. So the old tether system wasn't marked, so you could just kind of put it wherever you wanted to. Whereas this one was marked appropriately, so that there's kind of a leading edge and there's a trailing edge, and then it helps guide you to tell you where the tether should be anchored into the spine, and then also on your tensioning as well. So when you tension the tether, which is really the critical portion of the procedure, mm-hmm. You have to have that the tether go in and out of the spine, essentially in and out of the chest, to be able to get it down. And so the entire system works together. Before, they were using this tether, and I don't want to say it was the devices were jerry-rigged, but we were using instruments that weren't necessarily made for its intended purpose. Whereas now everything is made for this intended purpose, so everything fits together perfectly. And that's really a big difference. So the tether modifications were really a part of the global modifications of the entire system.
Very much integrated. So it's not as if the tether is new, it's just that the way it's delivered is new. Is that correct?
The way it's delivered, it's a little new. And like I said, the shape is a little bit different. The leading edge shape is different than the trailing edge shape. There's markings on it to tell you where, like the midpoint is, which is kind of what we call the working portion of the tether. So whereas the previous device didn't have any of those things.
And why is it important to have a leading edge that's different in shape than a trailing edge?
It's kind of like when you put a shoelace through a grommet in your shoe. Mm-hmm. You want to have that leading edge to be thin, tapered, and then just treated so you can get it in easily. So it's a technical point. It ends up getting cut off, because we don't leave that in there, but it just makes insertion of the device easier as opposed to putting in kind of like the end of a rope, which may be frayed or whatnot.
Okay, that's interesting, because I thought before the tether was kind of displaced within the screws, and then a set screw was placed on top, but now it's kind of tethered. Well, it's a needle and thread type of application now.
I don't know if needle and thread is like you still do kind of lay it on top of the tether. Okay. It's just it just helps with the initial entry into the chest. But the technique itself is very similar to previous. Like I said, the instrumentation is just a lot better.
Okay. Now, with the FDA approval of VBT, and it was in conjunction with Zimmer together, in order to do the FDA study, you had to stay within certain parameters, I assume, correct? Okay.
Correct.
And those are basically the parameters of all Shriners clinics, or it just depends on the particular experience level of the surgeon? Is there any kind of...
Yeah, it's interesting you say that. I would say everyone has a slightly different philosophy.
Okay.
I would say my own personal philosophy is I try to treat every child as an individual. You know, what works for Shaq does not work for your son, right? And so I really try to think about you know, what your goals are and try to marry them with the goals that I can provide for you. Some, you know, the tethers surgical indications as defined by the FDA are for skeletally immature children with a progressive scoliosis ranging from 40 to 70 degrees. In pretty much that's kind of a broad statement. Now, sometimes you'll have kids that fall outside of those ranges, and that's where I think surgical decision making comes into play. You know, we're in the middle of this pandemic, and so I just had a child who had to wait a bit because the hospitals were not open, right?
Mhm.
And so for me, ideal Sanders staging is really Sanders 3 to 5 is ideal, but sometimes you don't get to Sanders 5, you know, and if a kid is slightly above this, and Dr. Samdani and I just had this discussion together, you know, if you have a kid that comes in from a really long ways and you have this pandemic happen, are you going to do a different operation, even though, you know, like, you know, that kid is here from another country, you know, to get this operation from you? And ultimately, you know, using our surgical judgment, we both ended up doing the tether procedure, but just letting the families know, because we're a couple months delayed, we might not get quite as much correction. As long as everyone's okay with that and everyone's got realistic expectations, I think that's where, you know, that's where the shared decision making lies.
Okay. Now it seems uh, with the VBT for growing spines, am I accurate in saying that you kind of shoot for maybe around a 50% correction, and as they grow, you hope for another perhaps 25%?
That's dead on. So all of us shoot for about 50-ish% on the first standing X-ray.
Mhm.
And anything on top of that, even if you stayed at 50% and didn't get anything from there, to be honest, that's pretty good.
Yes.
But our goal is really to get to about 75%. And if you look at the more recent papers, Dr. Mianji's paper and Dr. Samdani's paper, you'll notice that they're getting about 75% mid to long-term correction. Um, and that, I think, is a realistic expectation. I don't think it's realistic for every child to expect 100% correction, nor I don't think we're shooting for that every time.
Hmm.
And it's because there is a chance of overcorrection. If you operate on a kid too early, you know, you'll overcorrect. So sometimes we try to undercorrect a touch just in case our timing was a little bit wrong. And so 50%, I think, is a reasonable indication, and that's what I shoot for as well.
Okay. Do you think as VBT continues to evolve, that those parameters will start to widen?
Yeah, you know, it's interesting. I would say I wouldn't put it past anybody. I know that there are centers that are doing more skeleton mature children or bigger curves. I think for me, you know, I trained in San Diego. One of my mentors in San Diego, Dr. Dennis Wenger, he was our fellowship director. Actually, he really had a belief that, you know, you have to always be careful being the first person on a wave. Just because if you're the first person on a wave, you you may be successful, but you may also, you know, not be doing an operation that's ideal for a child or a family. So that's part of my, you know, I thought a lot about that when tethering was happening, you know, in the previous form before it was FDA approved. I really
Mhm.
wanted to make sure that I had FDA approval on this before I proceeded personally. And that's kind of how I feel with the skeletal maturity as well. I know that there are people doing it. My mentor, Dr. Betts, does it. I think, you know, that's totally reasonable for him to do it because he's going to study it and he's going to talk about his results. Um, but I don't really feel comfortable doing that until I see a little bit more data.
Okay. Can I take you back to the overcorrection phenomenon?
For sure.
When, because I was always kind of thinking, I shouldn't say always, but if there's an overcorrection, is the greatest worry with that is that once it does overcorrect, you just don't know what else is going to happen to the spine in terms of other curves developing, that type of thing.
That's correct. So the spine is it's all connected, obviously. So anything you do in one part of the spine will affect the parts above and below. So if a child overcorrects, you're going to be creating another deformity that the spine has not ever experienced before. And so the curves above and below, the curves in your neck and the curves in your lumbar spine, or below wherever your last implant is, they're going to start to curve in the opposite direction. And if they start curving in the opposite direction and you're getting close to the end of growth, they might curve in directions where your discs are doing some kind of weird things to accommodate for, an overcorrected thoracic spine or overcorrected lumbar spine. So that's our worry. Like you said, things in the spine above and below. But also, our goal is not to give you deformity, right? In any plane. So I'd much rather underdo it by a hair than overdo it by a hair. The other part about overcorrection, a lot of times when things overcorrect, things really start to kind of, like the train kind of leaves the station and really starts to overcorrect the other direction.
Mm-hmm.
And so that's where you would consider revising and go in there to try to remove the tether or release the tether, are the two ways to do it. But thankfully, as we've gotten better with our indications, we have a better idea of when to do these operations. And then we have a little bit better of an idea on how not to get overcorrection. Not saying that any of us are 100%, even in the best hands. I would say 10 to 15% revision rate is reasonable to expect.
Mm-hmm.
There are some other studies, the older studies looking at Dr. Newton's studies showing, 40-something% revision rates. Those were the earliest tethers. Those were the kids that he didn't necessarily know exactly who we should be doing this on. As we've made our indications tighter and tighter, our revision rates have gotten a lot lower as well.
Okay. Now, speaking of different planes of the spine, there seems to be quite a bit of consensus around spine surgeons that once a scoliosis gets rolling, so to speak, and of course there are many factors that trigger it, quite a few unknown for sure. But once it gets started, there seems to be a phenomenon called anterior vertebral overgrowth, which causes a bit of an increase it causes vertebral wedging, where the anterior height is higher than the posterior height. And as a result, that causes rotation. Then the curve and the coronal curve starts to take shape. Now, I mentioned this to Dr. Betts as well in terms of I kind of visualize it as a spring that has to go somewhere, so it goes coronally or sideways. Now, with the tethering, or any procedure that tries to bring it back to center, is it kind of reloading the spring? If you go to
That's a great question. I mean, I think you're hitting the nail on the head. I love this spring analogy, and I'm gonna steal that one if that's okay with you, Dr.
Anytime.
Yeah. So most of us, most spine surgeons believe that scoliosis is caused by the front of the spine growing faster than the back of the spine. That's anterior overgrowth, like you said. And then the question is, well, why doesn't someone just keep growing into lordosis? It's because you have things in the back of the spine that are preventing the spine from wanting to go into pure lordosis or pure extension. And so, like you said, just like a spring, instead of going purely backwards, the spine actually twists and unloads through kind of a buckling mechanism to create that scoliosis. One of the biggest issues that we've had with posteriorly based implants is that when you do those implants, you really have to work hard to try to get that kyphosis back in the thoracic spine, because the vertebral bodies have changed their shape. Because they've changed their shape, when you bring everything back to the middle, everything stacks up into extension. And so you actually have to remove bone in the back through a procedure called pontiostiotomy. You have to remove bone so that you can stretch out from the back, so that essentially you're wedging through the discs. So it's kind of like you're curing one deformity, you're curing the scoliosis and the rotation, but then the bones are wanting you to go back into another deformity, which is the lordosis, or the loss of kyphosis. And then you have to do another operation, essentially another procedure, to get that kyphosis back. And so, it's this kind of balancing act that we have to do for posterior based surgery. The nice thing about anterior based surgery is, because it's on the front of the spine, you're loading the front of the spine, and you're making it so that the spine has no choice but to essentially kind of open up from the back, and to open up from the non-tethered side. So to me, biomechanically, it makes the most sense. That said, can we fix things from the back? Of course, there's a lot of things we can fix. It's just we have to do a lot more to get the same kind of result.
Okay. Now, with the tethering and being an anterior approach, with bone modulation being reduced, for instance, when you do the tether on the side or the apex of the curve,
Yeah.
or the convex side, has there been any kind of research indicating that you have greater bone modulation in terms of anterior to posterior with the tethering as yet?
It's interesting you say that. Michelle Marks did some work on the discs themselves, but I'm not sure if we have great data yet on the shapes of the bones. I think there is some early data that I've seen presented at some papers, but I haven't seen published yet. So I don't like to quote unpublished papers. I would say the answer to that question is yes. I do think that there is. I do think that there is some modulation of the shape of the spine, especially if you do this operation early enough. I don't know if we have enough data to say that that happens on every child, because really it's depending on how much growth you have remaining. But yeah, I think if you are loading one side of the spine, we know in orthopedics there's a law called the Hutter-Volkmann law, and we know that if you put pressure on a growth plate, which is really what the vertebral bodies are, they have growth plates on each side. If you put pressure on them, they don't grow. But if you put tensile forces on them, meaning you stretch them, they will grow. And that's the whole idea of the tether. So I would say the answer is I'm pretty sure they do. I don't have 100% definitive proof yet.
So. Okay, thank you. Well, some approaches with Dr. Betts, for instance, he does kind of try to make space in the anterior column by doing some disc release, right? I know it's a completely controversial topic right now, especially with growing discs. Do you have any opinion on that?
My opinion, like I said, I love Dr. Betts. I owe my entire career really to that man. I agree with him on most things. I would say I'm still a little skeptical on this one. I just don't have enough information to be able to make that kind of determination. I would say, at least for me right now, I don't do that type of operation. I know Dr. Betts has done this quite a bit. I think as he shares his data and as more surgeons learn about it, perhaps that's something we'll all end up doing. To me, it's just something that I'm not yet comfortable with, because part of the whole reason I want to do a tether is I want to preserve the health of the discs. I want the discs to be completely healthy so that you can live your life as normally as humanly possible. Taking the discs out with this procedure, doing this anterior scoliosis correction, to me is a little antithetical to what I'm trying to do. So that said, if you're a mature person, perhaps your goals are going to be a little bit different,
Sure.
And so since I only do the FDA indicated indications for it, I don't have to really worry about it. But that said, I would say, obviously I operate on plenty of mature kids. They get spinal fusions usually. I don't know the answer yet. I try to keep an open mind as much as possible. But that said, I can say for sure there's not yet enough data to support its use widespread yet.
Well, it's obvious that you're very particular and you're very careful with what you act upon. You need to see the evidence first.
Yeah.
Now, for individuals that can't do the tether, and I guess it would be interesting to know what percentage of kids who have scoliosis surgery have tethers versus fusions. But for those kids who can't have the tether, surgeons say that there's a huge difference between modern fusion techniques and older fusion techniques. Can you go into that a little bit?
Yeah, I would say there's been multiple generations. So when I think about the generations of spine surgery, I really think about modern spine surgery started in the 60s with Paul Harrington, the old Harrington rods.
Right.
The best way I can describe the Harrington rod, if you've ever seen the automotive anti-theft device, the club, if you've ever seen the red club you put on your steering wheel, that's basically what it is. It's the club, except instead of putting it on your steering wheel, you put it in the spine in between essentially either ribs or between different areas of the spine, the lamina. And that just provides a pure extension moment to try to straighten out the spine. It worked reasonably well for some people, but it really created some problems because it created a flat back deformity. And as we know, as we correct these curves, the front of the spine being bigger than the back of the spine, you really have this flat back deformity, and this straight rigid rod only exacerbated that. And so people were getting problems in the lumbar spine, the cervical spine, getting this type of device. And so kind of the next generation of implants was the segmental fixation. Eduardo Lucchi in the 70s came up with the idea of segmental fixation. There were wires around the lamina that were attached to rods. So we call that Lucchi fixation. It was really groundbreaking. So then the next decade, I consider the 80s the decade of Cottrell-Dubisset. So Yves Cottrell and Jean Dubisset in France, they came up with the idea of segmental fixation, not using wires, but using hooks. And so you would use hooks up and down in the spine in multiple areas to correct scoliosis. And that was popular for a while. In the 90s, that's when people started using pedicle screws, but only in the lumbar spine. And so we called those type of constructs hybrid constructs, where pedicle screws in the lumbar spine, hooks in the thoracic spine. Dr. Sook in, I think it was 96 or 97 at the Scoliosis Research Society meeting, he put up his first data showing pedicle screws in the thoracic spine. And, at that time, people were almost like booing him off the stage, saying like, hey, how could you do this? This is dangerous. You're a monster, and I don't know if they said you're a monster, but you know what I mean? Like,
sure.
But there were enough people that were interested in this that, went to see Dr. Sook in Korea to learn about this. Dr. Lenke in New York now, formerly St. Louis, Dr. Betts, Dr. Newton, Dr. Shufflebarger, kind of the greats of our field. And then I consider the 2000s to be the pedicle screw era. That's when we started using pedicle screws for almost, everything, like in thoracic spine, lumbar spine. And so really the 2000s is when I think kind of modern techniques and modern surgery started to happen. The devices really got good at that time. And then the 2010s was really when we started to think about, instead of fusing people, which we can do really well, what can we do fusionless? And so kind of it started, Dr. Betts's staples really started in the mid 2000s, but, started mid 2000s to early 2010s was the staple era. And then people really started using those tethers, I want to say in the early 2010s. And so we're kind of in that new era of technology. It's tether is a new technology. And I like to say to my kids, most of the kids that I operate on are too old for Rambo, but the parents may not be. Rambo had a lot of different arrows, right? He had like the regular arrow, he had the poison arrow, he had the explosive arrow. I consider tether to be another arrow for me. It's not for every child. I really don't think it's for every child, but I do think that in some children, it's perfect.
Okay. Now I want to touch on your work at the Tijuana Shriners Center. Are you going to be taking some of these tethering techniques down there as well, or is that going to kind of stay in Pasadena?
I would say, so I'm the chief of our Tijuana clinic as well. So we have a Tijuana clinic that's very busy. We do some spine surgery down there, but we don't do a lot of scoliosis surgery down there.
Okay.
We have a neurosurgeon that does our spina bifida, myelomeningocele type cases. But we send all the deformity, or spinal deformity or scoliosis up here
Mhm.
to Pasadena. And the reason we do that is I just think there's a lot of moving parts doing any of these types of procedure. And then whenever you try to replicate your, it's kind of like having a kitchen, you know, and if you try to replicate your kitchen anywhere else, things may be a little bit different. And there's just, I just think that the consequences are too high if something doesn't go right, that you don't want to blame it on your setup or, you know, your location. So we tend to do everything here in Pasadena. Now, will that change in the future? That's possible. We have a really great team down there, but at least for the near term, we're going to keep everything here.
Excellent. Okay. Thank you so much, Dr. Cho. You're very informative. Um, I got to ask you one last question though.
Of
How,
course.
how was it taking organic chemistry at Cornell? I have
Not only
nightmares from that myself.
Well,
Not at Cornell, but
not only was organic chemistry great, I was a
okay.
I was a TA for a teaching assistant
Okay.
in my senior year in organic chemistry. I think it's just like anything else. It's kind of how it's taught to you.
Yeah.
So for us, I was really fortunate that my very first chemistry professor was a wonderful man named Roald Hoffman. He is the 1981 Nobel Prize laureate in chemistry.
Mm.
So he was a huge influence on my life just to learn about chemistry and to show that it's not just memorization or equations that there's beauty in it. And then to learn about molecular orbital theory, it's really, there was a lot of drawing, there was a lot of thinking in organic chemistry, which, you know, I know my experience in organic chemistry is probably different than a lot of other people's experience, like yours, Dr.
Yes.
Lee. So I would say, you know, I enjoyed it. So
No, that's excellent. But it seems that seems the greatest influences during your career has been finding that those individuals who are exceptionally gifted at what they do, but who also can actually teach and direct you in the right pathway.
yeah, I think you hit the nail on the head. You know, and the nice thing about the tether community, the people who are doing the teaching, are really, you know, the pioneers, but they're all incredibly generous, nice people. You know, there's a lot of picking of people's brains. You know, that's why I'm talking to Dr. Samdani and Dr. Miyagi, Dr. Newton all the time, Dr. Betts. I really want to pick their brains on, you know, what do you think about this? You know, what do you think about my plan? You know, any things to watch out for. And we're just a really small, tight community. So most of us that do this know each other
Mhm.
pretty well. And thankfully, Zimmer Biomet's doing a pretty good job kind of picking out the people that can do it, that really should be the only ones doing it. They're not letting just anyone do this operation.
Okay, very good. All right. Thank you, Dr. Cho, for your time. I appreciate it.
Thank
And
you, Dr. Lee.
I think we'll have to do this in about 5 years or so and see what's new.
I'll be happy to do this anytime, anytime you want.
Okay. Thank you very much and have a great day.
All
Okay.
right, thanks.